Thank you, Joel. Basically, yes, I have got a splendid cold at the moment. I'm doing my very best. If the sound suddenly drops out, it's probably because I've muted myself in order to discreetly blow my nose and cough gently to avoid ruining your otherwise meticulous recording. So let me, I will hide myself and we'll carry on chatting for the moment. So, right, pediatric burns. It's never something you want to see, although I see 2,500 cases a year, give or take, through Chelmsford. And there have been a couple of recent experiences that we've had where there are definitely some holes in what emergency medicine, pediatric emergency medicine can provide. There are clearly some gaps in the network and capability, etc. So my aim today is to just talk about pediatric burns in general, and then we'll sort of drift towards just unpicking some of those issues that have arisen of late. Just a bit about me, not because I'm egotistical and a surgical flavour, but just because I have a slightly odd role in the world. I'm a pediatric burns consultant and adult burns consultant. I happen to also be the lead medical examiner for the trust. I am a senior lecturer in trauma sciences at Queen Mary's University of London. I run the advanced burn care course at the University of East Anglia, and I have two other university roles that I play. I'm a specialist advisor for the National Crime Agency and the UK Disaster Victim Identification Team. And just if that wasn't enough, I'm also 27 years in as a regular military surgeon. So I work within the army and have a number of deployed roles where I've dealt with overseas burns, shall we say, as well as military trauma, which also gives me the experience with resource limited environments. And although we pride ourselves in the UK as having a very resource heavy capability within the NHS, increasingly we're seeing a number of resources being challenged, shall we say. So where are we going to go next? We are going to look at trying to understand the diverse nature of burns. Again, it's generally not something that's taught within medical schools. If it is, it's a sort of maybe a 1 or 2 week taster where you happen to wander through a burns theatre, possibly see an outpatient or two, and often there isn't much sort of a coherent teaching and understanding of the underlying pathology and pathophysiology. So today we'll hopefully just run through some of that, give you a better understanding of what it means to have a burn, but also then look at how we can mitigate the burn, why burns are so bad, what the role of cooling is, and how that can influence a burn in the short term. We'll look at some of the physiological responses, including fluid resuscitation. Then we'll also just consider some safeguarding issues, and then I just want to drift towards the emerging issues of a burns mass casualty and what the implications would be for major trauma units or major trauma centres and trauma units within both this region and the UK as a whole. So hopefully you can all see a picture, and most of you, I hope, if not all of you, would agree that there are features in this picture that show a burn. For the interests of asking a question and having no one answer me back, I will just assume that there's nodding in the background and you all agree that if you saw this presenting to yourselves within the emergency medicine sort of role, pediatric role, you would agree that this is a burn. But why is it that you've accepted it's a burn? So admittedly, this is an old child, often known as an adult. But if you look at this one, I think, again, most people would agree that there are features they can see that are consistent with a burn. There's obviously the discoloration of the skin. There's clearly evidence of the change in the way that the skin appears. So there's redness, there's some thick staining, there's mottling, bruising, charring, carbonaceous deposits, areas that will feel thicker, more leathery perhaps, and again, many features that allow you to just say, well, this chap has had a burn. Now this one, is often also referred to me as a friction burn. In its strictly legal definition, this is in fact an abrasion, and therefore, if you call it by its proper name and you don't use the term friction burn, you don't refer it to the wrong person. An abrasion is mechanical trauma only that just affects the surface layer of the epidermis and the underlying dermis, and it heals by itself. It's, as I say, it's mechanical trauma. It's a little owie, and there is no burn component at all to the wound. So this is one of those injuries that is a true misnomer. However, there is one variety of friction burn that I am very happy to see. Surprisingly common, perhaps. I mean, we will see maybe 10 to 15 per year, which maybe doesn't sound that much, but when you see that's one every couple of weeks potentially that's being referred or discussed with us, and that's where a small person has watched mummy, daddy, older sibling, whomever it may be, using a home gym or having access to some sort of treadmill, and they go and explore it either when the said person is exercising and distracting, or when they've for some reason managed to find an on button and turn the thing on without anyone being aware of it, and they get their hand stuck on it. It suddenly moves it's moving very quickly. It pulls the fingers round and then wedges the fingers in the roller at the back, and so what they get is they are getting the initial friction component, but it's the friction that is generating heat, and the heat is then causing a very significant part of that injury. So there is a very clear distinction between those two different types of friction burn. The one in the picture that I'm showing you now clearly is very, very short duration. It occurs as part of a fall, a slip, and you just scrape yourself. That scrape does not generate enough heat to cause a burn. However, if the bits of your limb, hand, whatever it is, become entrapped within something like a treadmill, and they're there for several seconds while trapped, the friction that belt generates does cause heat, and it's that causes the more substantial injury and a true burn. And again, you've just seen this picture in a slightly zoomed in context. But again, what you're looking at here is what I would refer to as a classic skull burn. It's the classic pull down injury. The head is off to the left side of the screen. You can see the belly button with those two little small burns just below it on the right side of the image. There are sort of three components in that wound. You can see there's a sort of a broadly pink area that sort of surrounds the periphery. Then there is a sort of whiter, more yellow perhaps, a bit that's towards the clavicles and the sort of underneath the chin. And there's a sort of in-between bit that's sort of sort of where the Ziphus sternum would be. And these are three different types of burn depth, all of which have different properties, different appearances, and ways of being managed. We'll discuss those later. We don't see as many of this sort anymore. Often people will refer to this as sort of a squamous cell carcinoma or some other malignant lesion, but this is actually a radiation burn. Again, rare anyway in children, but we used to see a reasonable number. The modern radiotherapy dosing is just so much better now than it was 10 years ago, and just infinitely better than it was 20 years ago. The multifocal radiotherapy dosing means that you target lesions without targeting the skin and surrounding organs and structures. So all radiotherapy will cause damage to the skin, and 80 to 85% of radiotherapy patients will experience a transient erythema. That transient erythema is simply normal behavior. Another sort of 5 to 10% will get a little bit of blistering, a little bit of breakdown, and that can often be quite slow to heal, but nevertheless does get better as the keratinocytes, as the stem cells recover themselves in the base of the skin. And very few, maybe 2 to 5%, increasingly drifting towards that 1 to 2% range, actually break down as a full thickness ulcer and skin loss, where the radiotherapy dose has caused irrecoverable damage in the short term to a patch of skin. So this is a radiation burn for radiotherapy to the neck. We don't call them radiation burns anymore. If we call them a radiation burn, it implies that the oncologist or the person delivering the radiation dose miscalculated and has caused injury to the individual. So these are more appropriately known as radiation-induced skin reactions or radiation-induced dermatitis. It's quite a significant dermatitis if you get something like this at the base of your neck, but nevertheless, if we refer to those naturally sounding or non-inflammatory, not to blame someone definitions, then the legal teams are happy, and patients don't tend to try and sue you for doing something bad to them, even though you've tried saving them from their tumors. This, hopefully none of you have had, because you're all good, you all use the appropriate sun protection factor, and you don't increase your risk of skin cancers in later life. But sunburn is often referred to us. Sunburn, we'll go through the rationale for that shortly, but sunburn is sunburn. It's basically you've gone a bit red, you look like a lobster for 24, 48 hours, it hurts a bit, you feel a bit foolish, you moisturize it, the skin goes a bit flaky a few days later, and assuming that you recover from your skin cancer risk, all is well. So, there's no need for that to be treated as a burn. However, we do see some sunburns that manifest as true burns with quite significant blistering and quite significant injury and need for clinical support to manage what is occurring. And then we get the really nasty ones. I mean, this is a sort of very, it's a flame burn, but it's a couple of weeks down the line. But we can see in this wound multiple stages of injury, multiple stages of trying to heal. There's areas of overgranulation, there's areas of unhappy skin that is trying its best to heal, but it's in areas like the axilla, for example, where there's abrasion just because that's where joints and bits are moving. Skin rubs against all the other areas. And it's a warm, fluffy environment where bacteria congregate, have a party, and continue to multiply. So, burns I agree, look awful, but they also are a challenge to manage. And then this one here is a chemical burn, and you can sort of see that this is the back of a hand. This is an index finger and back of the thumb, where someone spilt a corrosive substance over the back of the hand. Again, not uncommon in children. Used to be more common when we used to have the non-locking lids that children could open quite easily. Obviously, they used to drink quite a lot of that as opposed to spilling it on themselves. But a lot of things that are under the kitchen sink are very, very caustic. They're very corrosive, and inquisitive toddlers will see parents doing what they consider to be safe things, and they don't seem to be hurt by it, so they'll have a go and do it themselves, just as part of their environmental learning, and often they come unstuck. So already I've started to show a number of things that would constitute burn injury. I get it. Okay, so far for a pediatric emergency medicine lecture, you've only seen adults. You're all thinking, I'm bored already. Is this Muppet for real? Does he know it's a pediatric emergency? Where are the children? We'll get there, but I didn't want to show you too many burnt children early on and upset you all. So when is a burn not a burn? We, the burn community, will define and recognize burns from multiple causes. Okay, we can have electrical, thermal, chemical. If we just concentrate on thermal, for example, there are we can break those down as wet heat, dry heat, and cold heat, or cold injury. So wet heat would include things like scald, sauna burns, high pressure steam injuries. Dry heat are the things like flash burns, flame, combustion, conflagration, contact. Circumambient, that circumambient is simply, for example, you're in a desert and you're exposed to an environmental temperature above that which is safe for your body, and the skin desiccates, you get crispy lips, and eventually you start to sustain skin injury. So dry heat, again, multiple different ways of injuring yourself. Cold, we haven't even covered things like frostnip, freezing and non-freezing cold injuries. All of these are relative, and that's only discussing thermal injury. So electrical, we can break it down as natural, man-made. We can add in extra things, as I mentioned earlier, like radiation. So the radiation dermatitis and radiation-induced skin reactions. Within chemicals, there's an entire subsection of corrosive injuries that we can discuss, but there are also non-conventional hazards. There's some that could be, for example, military ordnance. It could be living too close to a volcano. When the volcano goes bang, you get a whole series of corrosive substances, sort of toxic aerosolized gases, for example, can cause very nasty burns. We saw a lot of that when the White Island in New Zealand, when the volcano erupted there a couple of years ago. And I also had this other one, autoimmune. So you're probably aware of medical skin loss conditions such as Stevens-Johnson's and toxic epidermal necrolysis, possibly even things like staphylococcal scalded skin syndrome. But these are causing really quite profound skin loss to patients, and arguably behave almost identically, if not in an identical way, to burn injuries, the classic thermal burn. So when you start looking at all of these things all jumbled up together, and then I say to you, can you give me a nice clear definition? Most people start scratching their heads, quite rightly, and are challenged. They are challenged to find a definition. The thing is that the burn will always masquerade as many things, and often we have drifted down pathways that make the care bespoke, or they are chemical burns, they are cold injury, they are flash burns or arc injuries, or whatever we want to call them. But ultimately, they all come down to the same thing, which is that the burn is an injury to living tissue, and it must be living tissue. Otherwise, it's simply chemical or thermal decomposition, degradation, whatever you want to call it, of a substance. In the same way as you put a log on your log fire, if you have one, and set fire to that log, the log decomposes, it breaks down, it thermally degrades, full stop. Okay, but you don't get a burn if you burn a log, well, unless you're touching the log, clearly. So the burn it has to be an injury to living tissue. We recognize it's caused by a variety of injurious mechanisms, and it must breach the basement membrane. That is, it's the junction between the dermis and the epidermis. Okay, the epidermis being that dead outer layer, the dermis being the living layer. And if it only involves the epidermis, for example, like most sunburns would do, where you've got a natural erythema and some irritation of your epidermis that goes a bit crispy a couple of days later, that's actually not causing a true burn, okay? Because it has to then cause an inflammatory response that is greater than you would predict by the size of the injury. I get that last bit is a bit fluffy, it's a bit woolly, it's a bit non-specific, but it's that phrase that then unites everything about burn care. So, for example, in the sunburn, where you have managed to breach the basement membrane, you will start to blister. If you have got blisters associated with your sunburn, you've gone way beyond the sort of the sunstroke level, and you have got an inflammatory reaction that is now starting to become certainly local and regional, if not systemic. The same being true with thermal injuries. Once you've breached it, so for example, let's say we do a laparotomy, and I've got a surgical wound going from roughly the xiphisternum to somewhere around the umbilicus or just below it. Okay, if we measured the impact of a laparotomy just making the cut on the body, I would see virtually no rise in white cell count, a tiny little rise in the CRP potentially, recognizing that there is an inflammatory reaction just starting around that wound. But if I was to burn the abdomen, I'd see a huge rise in your CRP and a very definite rise in your white cell count, because it is triggering a much, much greater inflammatory response than you would see for the size of that injury. And this is the problem. Burns, whenever you have a burn, what you do is you will partly degrade the proteins, structures that exist within your skin in under normal circumstances, and in other soft tissues. They can be either non-protein or protein based, and as those little bits fragment and degrade, they create what we call DAMPs, which are damage associated molecular patterns. Those damage associated molecular patterns are recognized by the body as generalized badness, and every time an immune competent cell finds a damp, it will start to escalate an inflammatory response. So you can imagine that for a relatively small burn, where there is lots and lots and lots of damage to a whole wealth of non-protein and protein bits and bobs, there are going to be a vast number of damage-associated molecular patterns created, and each and every inflammatory cell within that area is going to go, oh, me first, and they're going to try to initiate their own inflammatory response. So very, very quickly, the inflammatory response almost overwhelms the local and regional areas associated with the burn. And once you get to a certain size of injury, broadly in that sort of maybe 10 to 15%, maybe 20% of the total body surface area, there is so much inflammatory response with each and every cell triggering its neighbors and its neighbors and more neighbors to respond to that inflammatory surge, that the inflammatory response becomes truly systemic and affects every organ system and every part of the body. So that inflammatory response triggers increasing vascular leak, whereby all the vessels become leaky. Fluid that should be within your intravascular space leaks out and starts to become tissue edema. That leads to a hypovolemic shock. And then associated with that, we've got a number of metabolic changes, which gives you a hypermetabolic phase. And then the body then tries to calm down the inflammatory response. It's desperately trying to mitigate the response that's going on. And actually what then happens is you get a counter-inflammatory phase whereby you become immunosuppressed, during which time your microbiome, whether that's the microbiome on your skin, in your gut, anywhere else, any other nooks and crannies and passages that you have, all of that microbiome also then becomes dysfunctional. And things that are normally protective for you can become pathogenic, and all of these things just start to influence how quickly you can recover, and the likelihood that you will develop things such as the systemic inflammatory response and or recurrent bouts of sepsis, each of which can lead to multiple organ failure, during which time, because you've got a burn that potentially needs surgical intervention or at least some sort of active wound healing, you've got burn wound progression that's occurring. All of these things are second, third, fourth hits, all have an impact on the ability of a wound to regenerate itself, to recover, or to heal if it requires skin grafting. So the pathophysiology, let me say that again, the pathophysiology of burns is all about understanding and arguably trying to mitigate the inflammatory response in the earliest stages of the burn in order to give the body the best chance of coping with the storm that occurs in its physiological responses thereafter. So when you look at all the different mechanisms, whether it be corrosive, heat transfer, electrical current, for example, all of those end up creating some form of injury to tissue, which ultimately creates necrosis. And if you remember, apoptosis is that bit whereby the body recognizes that you have an organized destruction of tissue. I've reached the end of my game here, says the cell, and I'm going to very neatly make my bed and lie in it and then dissolve gently without causing any problem to anyone else in the world around me. And that's great. That's heroic. We like apoptosis. What tends to happen in a burn is that you get an initial perhaps apoptosis phase, whereby cells will think about undergoing apoptosis, but then they run out of energy to do so. Apoptosis is an ATP dependent process, or they get the second and third hits. Basically, the body is overwhelmed, and what begins as an initial apoptosis leads into something called necroptosis, which is that initial phase of control that then fails miserably, and necrosis occurs. Whenever you end up with necrosis, you remember it's a disorganized, chaotic disruption of cells and tissues that creates an inflammatory response. So not only does the initial phase of the burn create inflammation, but then the ongoing necrosis where it occurs creates additional inflammation. And that's true with any of the mechanisms that we've alluded to as causative within a burn. So you will remember as well, hopefully, there are certain things known as the lethal triad. And the lethal triad is that coagulopathy, metabolic acidosis, and hypothermia that will occur in trauma in general, burns being perhaps one of the most serious, if not the serious, form of trauma, because of the wide range impacts that it has on physiology. It is very difficult in that early stage of a burn, because of the size of the wound, for example, to prevent hypothermia. You've got lots of fluid leaking out. You've got lots of a large surface area, for example, that is exposed to the environment. Therefore, not only does the large amounts of fluid leak, but also its evaporative losses. Wherever you have evaporation, you're losing heat. The burn itself creates lots of metabolic detritus, and that detritus starts to increase your lactic acidosis. The lactic acidosis increases your metabolic acidosis, it impairs your cardiac function. You've already lost more fluid into the tissues and into the atmosphere. So the reduced cardiac function in the context of your hypovolemia increases the risk of a hypovolemic shock developing. Now, the good thing in burns, if there is such a thing, is that the hypovolemic shock, the hypotension phase, is actually fairly slow onset. It's driven by the inflammatory phase. So if you have hypotension in the immediate pre-hospital or emergency department phase of a burn, they're either really, really, really bad with their burn, or there's another cause for it. Okay. And I think that's the thing that, it's one of those take-home messages, is that don't get distracted by the burn within the emergency medicine sort of phase, because any hypothermia that you see associated with a burn, it has to be investigated and an underlying cause of that excluded before you can assume it's the burn. Okay. I've seen some very nasty cases of other injuries being entirely missed until transfer has occurred. And there's been multiple efforts at 10 ml per kilo boluses trying to maintain normal blood pressures or near normal blood pressures, and actually what we've been missing in the background is an underlying injury, such as intra-abdominal bleeding or a chest crisis. So again, in the context of burn wounds, hypothermia, coagulopathy, metabolic acidosis is all going to add secondary hits to that initial wound, which makes the burn get worse over time. Why am I getting so het up about inflammation and pathophysiology of these things? Well, what we do know is that if you take this graph, for example, and you look at the darker solid line, that's the line I want. If I can get the inflammatory response to be mitigated, so the peak, the height of that peak to be as low as possible, then the downstream tail that I know is going to occur, it's inevitable. It's going to occur once you've had your burn, regardless of anything else that can occur. But if I can stop the peak being, if I can limit the peak, then the downstream tail will be shorter and the counter-inflammatory response will be less. But if I let that response just go nuts, then so that the peak is higher, then the downstream consequences will last much, much longer, and the depth of the anti-inflammatory response will be vast, which means that all of those derangements to organ function, the microbiome, immunosuppression, all of those things are all going to be much worse for much longer. So it is in our interests, my interests, it's in your interest to serve me, to do everything you can to mitigate where possible the peak of that initial inflammatory response. Now, lots of people get very excited about the threshold for burn injury, and there were some experiments done in the late 40s, sort of 1947, 1948, where a few pigs and a couple of lab volunteers, the authors of one of the papers from 1947 and 7 of his co-lab workers and or friends burnt themselves with controlled heat doses, and they were able to work out that the injury, the burn injury itself is logarithmic. So you can, but what they did work out that was actually quite crucial was that the threshold for cutaneous burns is somewhere between about 43 and 44 degrees. What they did work out was that at about 43 to 44 degrees, you'd need exposure to that temperature for about 6 to maybe 8 hours before you started showing signs of the most superficial burns. So thankfully, most of us, if we are exposed environmentally, let's say, to temperatures in excess of 40 degrees, have other ways of mitigating our surface temperature, whether that's by cooling, fanning, putting water on the skin, whatever it may be, sweating, for example. So actually, the threshold for burns begins at about 43 to 44 degrees, but you'd need to be really sustained exposure at that temperature to actually get a burn. However, as we start to increase the temperature, the time taken for an injury to occur becomes much less. And by the time you get to about 70 degrees, you only need about 1 second of exposure time to create a superficial dermal burn. But at about 50 degrees, it's something like about 60 seconds. So actually, the time and temperature profile of the injury is actually really critical to understand, and really subtle differences in the pattern of injury can be seen with even a couple of seconds can make a difference, providing you know that temperature well and you know what was then done as part of the first aid. So if we look at burn depth, I prefer personally the Australian classification system as described here, which is epidermal, dermal, and subdermal, for no other reason than it's anatomical. And when I say epidermal, you know what I mean by the epidermis. And when I say dermal, you know what I mean by the dermis. And if it's subdermal, it implies it's the bits underneath the dermis. So your subcutaneous fat and deeper tissues. The problem with the American system, which is known as the degrees, is that first degree, second degree, third and fourth degree don't relate to anything anatomically, and you have to know what you're talking about with them. And then the British system is superficial, and then superficial partial thickness, deep partial thickness, and full thickness. Again, it conveys what is damaged, but there's a lot of misunderstanding, and particularly because of the term superficial being used as in both epidermal and dermal injuries. Again, a lot of people, if you say they've got a superficial burn, a burn surgeon or a burns person with burns interest will say they must mean epidermal or first degree, but actually what they meant was a superficial dermal burn. Why do I get heads up about that? Well, any classification system has to be worth writing it down on a piece of paper or elsewhere for it to be worth anything at all. Now, the classification of burn depth is important because it very clearly dictates what things look like and how they're going to heal. And if we get that right at the beginning, we can set them on the right journey. So, for example, an epidermal burn isn't actually, by my definition, a burn. If it only involves the epidermis and it's just gone a bit red for a couple of hours or a day or so, it just means it's got a brisk capillary refill. It may, smart slightly, it may be a bit, owie, but actually no surgery is needed, and all of that erythema is pretty much gone within 2 to 3 days, certainly within 7 days. So, for example, a flash burn where something has gone bang, there's been a big heat dose delivered to the skin, but you've not yourself caught a light, you've not been exposed to prolonged contact with that heat, everything about you just goes a bit red. You look a little lobster-like for a few hours or a day or so. You might get a little bit of epidermal flakiness a few days after that, but actually there isn't that much of an inflammatory response, and there's nothing that needs to be done. There's no surgery needed, but very little actual care is needed apart from just a bit of soap and water, possibly a bit of moisturizing, and try not to do it again. The key one is are the dermal injuries. So, but all of those would be classified as second-degree injuries. The superficial dermal injuries are where you often see blistering. There's often a lot of redness. There's a brisk capillary refill, and there's often a lot of severe pain. Sorry, excuse me. Again, no surgery is often needed because there's very little damage to the dermis. All right, trying my best. And most superficial burns are going to heal well within 7 to 14 days. In children, you can often see a lot of healing within 3 to 5 days, such that the wound dries out, it looks less pink, it's got a less florid capillary refill, and their pain improves considerably within that 3 to 5 days. But for the skin to become robust, able to resist mechanical abrasion, for example, it takes a little bit longer for that new layer of epithelialized skin to toughen itself back up. Deep dermal burns, again, are often relatively easy to recognize. They have a slightly darker, more cherry red color. There's less capillary refill to them. They have a mottled appearance, whereas the blood vessels have ruptured, and you might see little sort of almost like thread veins within it. That's clearly representing a deeper injury, but it doesn't mean it's non-salvageable, because there is an option there for some of that dermis to sort of almost regenerate itself, to recover. But it needs really good wound care in order to optimize it, to prevent further drying out, and to prevent the progression, converting that deep burn into a full thickness burn, into a subdermal burn. So for most deep burns, surgery will be needed, but you can initially manage them with a bit of watch and wait, watch to see what happens. But the majority of deep burns, unless it's a very small patch within a larger burn, for example, most are going to require surgery probably within that first week. Between those two categories of in the mid-dermal range is a definite category where there is more superficial than there is deep, and you will give that time. And often we will give it a good 2 weeks, because actually, if I can get a burn to heal without a graft and a new donor site, it is more likely to heal without evidence of that scarring. For example, whenever you put a skin graft on, no matter how good you put it in, you're going to see some form of edge. There's going to be a boundary transition zone between the unburnt skin and where the graft is sited. So where possible, we can let nature do the hard work for us. But once you get to about 10 to 14 days, if you're not seeing the forward momentum, we're not on a trajectory that is encouraging, then we would start to talk about surgery. The key thing as well with subdermal burns, full thickness, is the American system of 3rd and 4th degree. 3rd degree means it extends into fatty tissue. 4th degree, it's going into the deep structures like muscles, tendon, bone. From my perspective, that's an irrelevant classification, because once you're full thickness, it's not coming back. You cannot resurrect that tissue. You are going to need surgery to do something about it. So whether it's 3rd or 4th degree is irrelevant. Once subdermal, unless it is like a tiny pinprick of subdermal injury, it's going to need surgery. So getting a good assessment of burn depth as early as possible really does help us work out a treatment trajectory. So this is again a pull down injury. You can see that there's clearly an involvement of the airway, and what was there must have been fairly hot, because there's a very nasty mottling of the chest. You can see how it's tapered down towards the sort of the nappies, into sort of the underwear, and which again is what you would expect from gravity. Some of it is going to be absorbed into clothing, for example, around the shoulders and the upper chest. There's less volume available, and as it flows down towards the sort of the pelvis and genitals, and so you end up with less less volume to spread out, and that classic sort of tapering appearance. You can see at the very edge, there's that surrounding pink halo, which is most likely superficial or superficial dermal, and it's going to progress into that slightly paler zone where there's a mid-dermal component becoming a deep dermal component, becoming that central sort of V where it's all mottled and sort of yellowy and it just looks rather unpleasant. That is all going to be full thickness. So virtually every burn, unless it's an experimental burn, will be heterogeneous. There's going to be multiple burn depths within every burn wound. This is an extreme example. But this again is a not uncommon pattern of injury where there's been a splash in a slightly older child who has managed to do her best to sort of avoid and jump away, but then she's got splashes to the hands, to the wrists, to the fingers, and bits to sort of lower abdomen and inner thighs. Now, if you look towards the inner thigh, you can see that there's a slightly darker area. It's got that darker red. It's becoming a cherry red. If you zoomed in a bit more, you'd see that there are the little broken blood vessels within it. So clearly there's a little patch there within that thigh, on the innermost thigh there, which is deeper dermal. Okay, that's a deep dermal injury, but there's bits as you poke it that will look, they're going to try to blanch. So there's a little bit of life left in it. And the inside thigh is notoriously difficult both to graft and to nurture, though, because it's thinner skin. It's inherently thinner. I'm not suggesting you just go and tweak the inside of your thighs at the moment just to do a sort of pinch test. But if you pinch the outer thigh, you can feel that there's some thick dermis there. As you move to the inside thigh, there's clearly a difference in the depth of your the thickness of your dermis. But the majority of this burn has a superficial element to it. It's nicely pink. You can see it's glistening. It's very, very wet, and that means that most of those superficial the dermal plexuses, the outermost layer of blood vessels, are still intact. If they weren't intact, they wouldn't be leaking. So for the wounds to have this very wet, glistening appearance means that at the moment they are certainly present and doing their best to well, hopefully to try to survive. If we look at same child, this is the splash that was occurring to the side of the torso, and again, you can see how wet and glistening it is. So this is definitely a superficial dermal burn, and something that we could let nature try and look after for us. The thing that we need to work out, though, is how much area is involved and how much of that area is sort of risky and at risk of conversion, getting deeper. So inherently, actually, the area of her shoulder is the bit overlying her acromioclavicular joints and the sort of clavicular heads. That in everybody, even in your plumpest little child who's got all the body fat that that makes them all cute and dumply, actually that clavicle is still pretty thin. So a burn over a clavicle over those less padded areas is going to have more influence and impact than over a well padded abdomen, or sort of a nice meaty thigh, for example. So the good news for this young lady is that's what happens. This is 18 days later. If you look closely to the image on the left, you can just make out down the side of her chest that there is a pigmentation difference. I mean, again, I can see that there is a very faint outline of where that burn was, but what I know is that this is only 18 days. By 3 to 4 months, her natural pigmentation would have started to come back with a vengeance, and I know that by the time we saw her at 6 months, there was virtually no sign of that burn at all. The difference is, as a parent, as someone who deals with burns, you can normally look at the skin and just see something. You will always notice there's just that little something that wasn't there before they had their burn. And often that's one of the things I will tell parents is that, I expect this burn to heal, 100%. Nature is going to do all the work for us. In terms of scarring, there will be no scarring that's going to have a functional impact on your child. However, as a parent, you may see something. You may always notice a blemish, a textural change, just a slight discoloration, a something that wasn't there before, because you know where the burn was. You remember the trauma associated with it for the individual, the patient, for them as the parents, and all the other, factors that come together. The blame, was it them that made the cup of tea? Did they leave it within reach? All of these factors all add together for them just to look for every slight blemish as a reminder of quote, a permanent scar. Okay. Is it likely to be a permanent scar that has any other impact on their quality of life? No. Which is great news. For the vast majority of the patients we see, they don't need any real sort of long-term follow-up for their scar. What you will notice is even that deep patch, the arrows just highlight where the pinker blemish, just in case it's not coming out on your screens. But if you look at her other thigh, the inside thigh, you can see there's just a slightly paler on my screen, slightly maybe more sort of mauvey lilac-y appearance, which shows that even that deep dermal bit has healed at 18 days. It's coming together. Nature is healing it for us, and it looks a lot better doing that than it would have done sticking a big skin graft on it. So again, this is an important chart, okay? If you get the burn depth assessment right and you do the right things and you support and nurture appropriately, then you will get a good outcome. So burn depth and cooling, right? So this is one of those things. If we talk about cooling, the current guidelines would suggest it's about 20 minutes of tepid, preferably, running water. It says cold running water in a lot of these slightly older documents, but ideally it would be household water temperature. Now, most household water comes out of the tap at somewhere between 12 and 15 degrees. That's just the temperature it comes out with from the mains. We've tried to move away from talking about cold running water because that still makes people go to the fridge and get out the ice because they think that the colder it is, the better it is. If I picked on one of you and burnt you with something just to because I can, but I was filming it using a thermal camera, what I would see is that there would be, let's say the temperature, it was 80 degrees, okay, 60 degrees, I don't know, something hot. If I watched I did nothing at all to that wound, the temperature would return more or less to the pre-burn temperature within a few minutes. The heat, the rate of heat lost to the environment, that the skin temperature would be initially 60, but it rapidly dropped to 50, rapidly dropped to sort of 45, rapidly dropped down. Let's say your skin temperature pre-burn was 20-ish degrees, maybe 25 degrees. It may not get quite back down to that baseline because you've now become hyperemic. You've got a burn. So you've got more blood vessels dilated and there's heat in the tissues coming from inside your body. So it will be slightly warmer than it was before, but it's largely lost the heat within a few minutes. Okay, so it may get down to say 25 to 28 degrees. But we know that burn cooling is effective, most effective within the first 20 minutes, still effective up to an hour, and definitely has an impact up to 3 hours after a burn injury. So burn cooling is absolutely nothing to do with taking the heat out of the burn, okay? That's what everyone else will tell you, but it's rubbish. So the reason that we do it is it's all about that initial inflammatory response. Effectively, when we have a burn injury, what we do is all of the tissues, as I said, that have been injured, effectively vomit all of their damage, their damps, all of that that degraded tissue, all that degraded substance within them. They're vomiting all of their inflammatory triggers and all of that debris into the cells around them. They're vomiting all over their neighboring cells, and they are all of their neighbors, quite appropriately, vomit as well, because nobody likes being vomited on, and it makes you sick as well. So you've got this massive vomit storm going on in the skin. Every reaction in the world has is temperature dependent. The warmer something is, the quicker it occurs. So actually, when you cool the skin, what you're doing is you're actually dampening down the rate of spread. There will be a bit of vasoconstriction, not much, but there's going to be enough to just limit the rate of the vomit response and limit the rate of spread within the tissues of that inflammatory, of all those secondary messages, of all those inflammatory mediators, which is why it's effective up to 3 hours, because you can still limit those secondary messengers in the tissues. The problem that we have is that whenever we cool the burn, but we also cool the patient. So you never, ever get a child with a burn who you can hold under a shower head, like this little one here on the right-hand side, that just sits there going, cheers, mum, thanks, this is great. Okay. They are screaming, they're scratching at your eyeballs, they're kicking, they're doing everything they can. They're probably even pooing on you just because they're so annoyed with the world at the moment. So trying to get 20 minutes of good first aid in a screaming pediatric patient is nigh on impossible. Okay. And but just because they get 10 minutes, 10 minutes is better than nothing at all. Okay. But neither should we necessarily criticize people unless we actually are willing to accept how difficult it is in these circumstances when you're distressed, child is very distressed. It's just everything's like your worst nightmare coming true. You're not thinking irrationally. You've got to try, you just try your best. Okay. In the meantime, while you're trying to shower the child, you've got someone from 111 or 999, talking you through all of the things. And it's utter chaos. It's utter chaos. So again, I think we have to be a bit pragmatic on what we advise. There is a right thing to do, which is do your very best to cool, but you've also got to think quite pragmatically about what it is you're cooling and how. And again, we've had like near immersion injuries where someone has, on the 999 call has said, try, run a bath of cold water and try and get some cooling done. And effectively, parents have, run it with cold water, dunked ice cubes in the water to make it as cold as they can, and effectively, tried drowning the child underwater so that they've actually got 20 minutes of cooling therapy. And the child turns up with a temperature of like 32 degrees or less. So again, you've got to be really careful how you describe it, understand what it is that it's trying to do. It's not taking the heat out of the burn, it's just trying to dampen that inflammatory response in a way that's practical and achievable, and make sure we give advice that's clear for those distressed relatives and parents. And then we get to another minefield. Gosh, right, food resuscitation. This is the sort of adult formula. Yes, I know they're adult, but there are two vastly different formulas. One's 4 ml per kilogram per percent TBSA. The other one's 2 ml per kilogram per percent TBSA. The Parkland formula is sort of the UK standard, give or take. But it's a reasonable volume. And if you give reasonable volumes to patients that can't quite tolerate it, you will get fluid creep. Fluid creep is where you are giving excessive amounts of resuscitation, so you're actually maintaining organ perfusion, but the extra fluid is going elsewhere. And where does it go? It sits in the tissues, it sits in your lungs, it sits in the bowel. So actually you cause over resuscitation related problems. Equally, the modified Brook is 2 mils per kilo and does very well, but carries a risk of under resuscitation. And there's always these issues about how much you can give pre-hospital, whether it's crystalloid, whether it's colloid. It should always be warmed, for example. Over the years, they've sort of drifted together, and we now refer to this thing called the consensus formula, which is halfway between the Parkland and the modified Brook. It's sort of 3 mils per kilo. But pre-hospital issues can still remain, but there is a sort of better global conformity in what it's trying to achieve. The rule of 10 is an interesting one from an adult perspective, if anyone's super interested, or I can go through that, but I've crossed it off this slide on purpose. The problem is that children they have a lower threshold for resuscitation. Okay, so in children it's 10%. Adults, we take 15%, although the guidelines might drift towards 20% over the next couple of years. The problem is at 10%, that's the whole head in a 1-year-old is maybe 16%. So you don't take much of a splash to the head to get near 10%. And then you start going nuts and giving them 4 mils per kilo or something as part of a resuscitation protocol. And they will get edema-related complications. They get gross swelling and soft tissue edema. They can obstruct or certainly occlude their airways quite quickly. They will get an acute lung injury. They will get some, a degree of ARDS. They're going to have, wet lung. We can increase the risk of a compartment syndrome. That in its own right can increase the risk of something called non-occlusive mesenteric ischemia, which is the underperfusion of the bowel, and you can get ischemic gut. Inevitably, you will have gastrointestinal stasis. You got to remember, as I said, the inflammatory response affects every system. So what you're seeing in the skin as swelling is also being manifest in every other organ system, which is also, if you were to do the post-mortem, looking incredibly boggy, squishy. The bowel will just expand to become, fill the entire abdominal cavity, and just look horrible. Meanwhile, all of the perfusion that's going to it is being compromised, and you end up with a pseudo obstruction. There is, a gastrointestinal stasis, which leads to malabsorption. So impairment of normal function will occur in every tissue system. And I say it is a real problem. So actually, the over-resuscitation is something that we must avoid. But if we get it wrong and we end up with an under-resuscitated child, they fall off their perch very quickly. So food resuscitation has got to be really carefully balanced. So we did some work at Chelmsford over a few years ago, and broadly, we sort of go a bit off piste now, and it's spreading around the country because there is logic in what we try to do. In essence, if you have a child that is more than 30 kilos and has a burn that's greater than 15%, you just give them 4 mils per kilo like an adult. You don't need any maintenance fluid because there is enough volume in the 4 mils per kilo to cover their maintenance and what they require to maintain organ perfusion. If they are, however, under 30 kilos, but have a burn more than the 10% current threshold, you aim for 2 mils per kilo, but with whatever is your locally recommended maintenance fluid. The reason I say with a suitable maintenance fluid is that there are actually quite a number of variations now, and the old sort of dextrose-based teachings are not always, well, there's variation. Let's just leave it as that. There's variation. So your maintenance fluid is whatever is your host trust maintenance policy, your pediatric guidelines. You just give that maintenance appropriately for children under 30 kilos with a burn more than 10%. But we only resuscitate them at 2 mils per kilo. And if we do that, then we see that there is a good balance between the risk of over-resuscitation, the risk of under-resuscitation, and a balancing of the risks and benefits of resuscitation versus the complications. The key thing is it's got to be collaborative. This might not go in line with your trauma resuscitation guidelines, but your trauma resuscitation guidelines are very specific towards the few things in children that cause hypovolemia, which are generally things that you can turn the tap off quite quickly for and are short-lived. These are 24-hour guidelines. We're giving this rate for normally about 24 hours. We're trying to stop all the other things like the burn wound progression, etc. So it's a problem, and we can advise you. You might get variations on this, but what we're trying to do whenever we give you the advice, when you're trying to refer a child to us, is give you a bespoke formula that is going to try to balance all of the multiple risks that we're trying to compete against. So just going to talk about some pitfalls. This child doesn't have a burn. There has been a scald. I completely agree. There's lots of redness, but there is absolutely no blistering. It blanches well. It hurts. The child is unimpressed. He's unimpressed because he's also been dipped in the in his bath maybe for 20 minutes. So he's a bit hypothermic, and then we keep taking his clothes off to take photos of his chest, and he's just fed up. Does he have a burn? No, but if you look at his chest and you use the London Browder chart and you look at the redness on his arms and you say he's got a 16% burn or an 18% burn, and you've given him several hours of resuscitation, he ends up being a boggy little child with that's grossly unimpressed, peeing 8 mils, 10 mils per kilo per hour. And we've done him no favors at all. The key thing is really trying to understand that erythema is not part of the burn. It must not be included in the burn assessment, and actually, because if you do include it and you include it in that resuscitation formula, we will run into all sorts of really bad complications with over resuscitation. But also, we've got to appreciate that little people are not adults. They have their own little anatomical proportions, and it changes quite significantly as time goes by. So, for example, a forehead in an adult might represent 1.5%, maybe, give or take. It's very rarely going to be anything more than 2%. But the head of a 1-year-old or a 6-month-old, something like that, is about 9% at the front and 9% at the back. So proportionately, a forehead burn could easily represent 3 or 4%. And again, we have seen a number of children over the years who have been assessed according to an adult London Browder chart, and their total burn size has been under-recognized, and then they've been transferred with a 3 or 4% burn, for example. When we've upgraded them to a 14% burn. And you sort of go, well, how can there be such discrepancy? It's simply down to not recognizing that or not using the age-specific London Browder charts. And again, a child that's been under resuscitated for 6 hours can end up in a fairly shocked state, needing admission to the burns intensive care unit. And then proper redness. Man, look at this. But no history of a burn. So this is most likely something like a staph skin syndrome or other sort of medical skin loss conditions. But equally, it's really nasty. This is a big surface area that is with lots of shedding of the surface of the skin. Kiddie getting progressively and fairly rapidly unwell. Started to get mottled and shut down. Something that can be managed within the pediatric service in most circumstances, but when it becomes really severe, really, really significant in terms of wound management, then sometimes these are things that do need to be discussed with a burn service, not least of which because we can just manage the wound. We can scrub it, we can clean it, we can put the right dressings on it. We've got the warmed rooms, we've got the capabilities and the resources to manage the wound for just that 24, 48 hours. That may be all it requires. Epithelialization can begin again if it is a true staph scalded skin. If it's an SJS TENS, again, they're going to be sick. They're going to have lots of ITU requirements, and they may need quite significant critical care support. And then we've got to be careful that we don't make things worse. So this little child presented with the classic pull down. He's a right age, right mechanism, reaches for the cup of coffee. And if you look at the smaller picture on the left hand side, sort of down by the umbilicus, actually it's all beautifully pink and soaking wet. There's absolutely everything about that screams out, I'm a superficial dermal burn and I am going to heal. Just look after me. A couple of days later, child is in theatre. And possibly for two reasons. Reason number one is if you look at the bit that's now at the just below the umbilicus, you can see that it's converted. There has been some burn wound progression. The burn wound progression has converted that whole thing to a full thickness burn. The reason? Because he was wearing a nappy, and it's just pressure. So where the nappy was put on firm and constricted the burn, it reduced the blood supply to the area. And what was a very salvageable superficial burn then didn't get enough blood to maintain it, and it became it's a secondary hit. It started to convert. So unfortunately, this poor child needed a small excision of this otherwise happy-looking burn and a skin graft around his lower abdomen. Occasionally, we will see a not dissimilar pattern of injury where the burn has just got a bit of localized infection, and they present with something like toxic shock. So again, a relatively small, superficial looking burn that causes no concerns initially suddenly presents with the temperature and, maybe sort of, diarrhea, other sort of symptoms, or, progressive and fairly rapid shock. And and has the features of a sort of staph toxic shock syndrome. And it may just be from something as trivial as a tiny piece of conversion in the burn that's just allowed a staph colony to start to produce something that's not good for the child. And then we get the more complicated injuries, which again, I don't think anyone's going to argue with the fact this child needs intubation, but intubating children, if you're receiving this in an area that is not resourced and doesn't always see children. Again, quite often now, pediatric emergency services are slightly separate from adult services. And once you've intubated it, you've then got to do something with it. A lot of critical care services now are very, very specific. And you've then got to get the pediatric retrieval teams. You've got to engage with whatever those retrieval teams are called these days. They have lots of little different acronyms. But this is, in the old days, this would have been a time-critical transfer, and we would want to see this with a degree of urgency. Often now, we don't. They are time-critical, but there's so much other bureaucracy and stuff that needs to be done, all for the right reasons, for patient safety and making getting the right person to the right place at the right time and all that sort of stuff. But this sort of thing can remain in your department for some time, and we would be asking you to be doing things for it to make the outcome better and prevent the problems that we know will emerge. And again, nobody wants to see a child like this. It's over the years, I mean, I've been doing this more than I don't know, 20 years, 10 years as a consultant. So I've seen lots of nasty burns, but these are really, really horrible. And actually, if you've got young nurses, young doctors working with you, with young families, all they see is their own child lying there on the table, and then we're saying, take photos, clean it back, de-roof blisters, wipe things, and you're going, you must be mad, you must be joking, that's horrific, why are we torturing this child, etc. Well, you're doing good by taking the blister juice is all pro-inflammatory, so the quicker you can remove that tatty bit of skin and the nasty juice that's underneath it, you're actually preventing the burn wound from progressing. Equally, all of that juice, as it leaks, pops and accumulates, then evaporates and adds to the cooling. And it also just makes a mess of everything around you. So lots of the things that we would ask you to do are actually in the child's interest, but for very practical reasons. But I completely get it that what I do as normal in my day job, weird as that may be, is something that is just traumatic for you to do when it's just something that you just don't do. But again, collaboration, you've got to, if you understand the reasons we're asking you to do it, not just because we're being annoying, then hopefully, as I say, it means that the child gets a better outcome. And this is one of the big issues at the moment in all forms of burn care for emergency departments that are not co-located with a burn service, is pediatric escharotomies. Of several cases in the last 3 years, we've had some quite nasty consequences where emergency departments have been unable or unwilling to do escharotomies because it's out of a comfort zone, or because we've not had pediatric anaesthetists or pediatric surgeons of any flavour who are willing to lay their GMC registration or other PIN number for doing something that they've never done before. And again, I think we get that, we understand it. We're not unable to appreciate the nuances. But when you've got an involving compartment syndrome in a limb and you're in a DGH treating a child with a nasty burn who you can't transfer to us acutely for whatever reason, actually that escharotomy is a time-critical intervention, and it is something that is really, really important. I know that the escharotomies are becoming, they're now part of the emergency medicine syllabus. And some of this will hopefully start to improve in the coming years, but it's not going to be a short-term fix. This is something that's going to improve over years, not months, for example. Right. Let's move on. So I think, again, it's just pointing out the obvious. Burn care itself is a lifelong journey. There are lots of things that we have to do at the very beginning that get kiddies improved and out of hospital early, in entering as that rehabilitation and recovery phase. But there's also lots that we can do, from education and training, from educating the wider team, whether that be nurses, family, the police, future employers, families, friends. The list is huge. I think one of the things that I would reiterate is that the Children's Burn Care Trust, Children's Burn Club, there's lots of these things around, and again, even just giving parents little bits of advice early on, reassurance, while they're waiting for transfer, for example. I know this is going to be horrible for you, blah blah blah, but maybe just check out this website, the Children's Burns Club, things like that. They will look after you. There's so much support out there, and every burns patient that's referred to us gets access to a psychotherapy team, particularly the pediatric element. But then that element links in with their school, or nursery, and the team that might be looking after the nursery workers, so that everyone understands what the child needs with their burns to get the case, and so that they don't get that sort of separation and sort of not victimization, but they're not getting separated out as being somebody different. If you integrate the child normally, then and you don't treat them as a burn survivor, you just treat them as a child, they do fantastically well as they grow up. I know I'm coming to the end. I've got about 15 minutes or so, so I'm just going to go through a couple of things a little bit quicker, and just with a few take-home messages. Burn prevention strategies, my word, in my career as a burn surgeon, these things have been they have changed the profile of what we see as burn injuries. So the little group of 4 on the right side there, flame retardant fabrics. When I was a kid, I can remember clothing just going up, just that was it, gone. It was the new nylons, man-made fibers. Woohoo! Yeah, they're great. No, they're not. They go up like nobody's business. You might as well cover yourself in an accelerant. Then the laws changed. All children's clothing has to be made of flame retardant fabrics, or their bedding, all that sort of stuff, because and things like furniture within living environments, things like that. It just means that it buys you that minute or two before the flame retardancy fails and it becomes and true ignition occurs, or if something starts to smolder, it doesn't rapidly combust. And that's the difference between there is a burn and I'm trying to get out, and I can open the windows, open the doors, and I can evacuate from a building. Or if I spill something onto my clothing, or as not that a child would be smoking, but never say never, but if something is a heat source falls onto the child, then their clothing doesn't just ignite and cause nasty flame burns. The other thing here is an immersion heater. By law, they're not supposed to be set anything above 60 degrees now. And if the heat that comes, if the water, that comes into domestic living areas, such as bathrooms, that should have a limiter on it to 48 degrees. I said that the burn temperature of the threshold is 43 to 44 degrees. Well, at 48 degrees, you'd still have to have contact with that for an hour or more for it to cause a burn. So actually, if it feels hot at that point, you move away from it. At 50 degrees, again, we said earlier on, you've got 60 seconds at least. So limiting the temperature has been critical in terms of the number of scald injuries that are seen within things like baths and domestic settings. Smoke alarms, barn door obvious, and fireworks. Actually, by limiting the sale of fireworks to certain periods, actually what we've got is we've vastly reduced the number of sparkler injuries, and we have limited the number of inadvertent accidents. Also, they're cheap. It's better to go and see a big display. You get greater volume of fireworks. There's lots more oohs and ahs. You don't have to watch dad putting something rubbish in a milk bottle and then watching it fire off for a single bang. Actually, simple changes to how we do stuff has actually vastly reduced the number of burn injuries we see in children. That said, I draw your attention to the photo of 4 very happy Halloween children, who is the greatest threat to children in my working career. The reason being is that all of the clothing they're wearing is not classified as clothing. If it was clothing, it would have to meet the legislation that says it needs to be flame retardant, fire retardant, and all the other bits and bobs that go with it. When you see these monstrosities hanging up in shops of many flavors, they are classed as toys or promotional items, and as such, like every piece of cheap plastic that your children want when they go to the shops and they see some magazine with a bit of plastic attached to it, and mummy, I must have that, please. They do exactly the same with these items, and all they're doing is buying themselves an accelerant which they wrap themselves in, and then they go to a Halloween party where someone has got like a birthday cake or something, and they've got candles all over the birthday cake, and everyone says, lean forward and blow out the candles on your birthday or your other special surprise or whatever it may be, or come to the fireworks evening in your Halloween outfit, yes. And you're basically taking a live grenade somewhere. So I have personal hatred of these things. They look great, don't get me wrong. Everyone loves a good bit of dressing up. But my only request of the world is that these things are classified as what they are, which is clothing, and they're made fire retardant, and then we don't see children going up like proper candles every year. Anyway, there's that soapbox done. So a couple of little safeguarding issues. My gosh, proper questioning. We get loads of things referred to me as a safeguarding question, shall we say, and almost immediately, most paramedics, ambulance crews, a lot of emergency departments, in all fairness, refer stuff in as a safeguarding issue. A lot of the time when you talk to parents, they're doing what is here. It might be not the most sensible thing to have done. You're working at your laptop, you're drinking your hot cup of tea, you're bouncing the kid on your lap, you've got no sleep from last night, and then kiddie reaches out and knocks the cup out of you, and you spill the hot drink on themselves. Would you really have done it if there was another way of doing it? Again, the inset picture, mum cooking dinner and kiddie on their lap. It's just these things happen. I think the key question is there a genuine safeguarding concern, or is this intentional injury? Do you genuinely think this is a non-accidental injury or an intentional harm to the child, or is this simply families under pressure? And there's a difference between families under pressure who need social care support. What they don't need is being kept in a corner and told that they're being referred for Section 47 investigations and the like. And again, we make rods for our own backs. We do things. We inspire. We let kids in and out of kitchens. We show them how to how we do stuff. And we think we've put things out of reach, out of danger. But I've seen kids act like Superman, for crying out loud. They're there one minute, gone the next, and they leap and climb and are very, very clever in many occasions to put things together. The classic iron burn. We still see a number of these, but the vast majority of them there's nothing about them that's malicious, and we go, oh, it's an iron burn, they must have, they've been, hell. No, if you listen to how it was done, and you can often tell by the pattern of injury that when an iron falls, the hand, these things are at 180 degrees, maybe 200 degrees, like hair straighteners, up to 230 degrees, ceramic hair straightener. You need contact times of 1 to 2 seconds. You're going to have a full thickness burn. So actually, even the sharpest response of pulling your hand away from something, you're going to get left with a deep injury. But you can often tell with the pattern whether it's been held, i.e. pressure has been applied, or whether it's almost like a glancing blow. And sometimes I do I do wish that we had a chat with the burn service first before escalating to Section 47s and sort of safeguarding investigations. And I get why we have to do that, but I also think it at times of stress for parents, it adds a lot of extra woe to their already woeful lives. And again, this child got a skeletal survey for this injury because it was deemed a pattern that couldn't be explained. And I'll come back to that one. This one is an interesting child who managed to climb into a sink while his mum had been prescribed some new medicines and was rendered a little bit unconscious, shall we say, or not unconscious, rendered difficult to rouse. So the child had gone like he would normally do to run a bath, but instead ran some water in a sink, climbed up into it, and then sat in the sink. Then, because the tap was still running, and the sink started to overflow, didn't get that temperature sensation that it was getting too hot, and then couldn't get out of the sink. So was screaming for mum. Mum sort of woke up, was a bit sort of disorientated, went to get him, brought him out, and called the ambulance immediately. Child gets to the emergency department and has got a lactate of 8. Is mottled across everything from basically umbilicus down is mottled, not very responsive, gets some very, very good resuscitation. And but then everyone just says, well, he's clearly been held in the sink. Look at that straight line. That's a fluid level. Mum's talking rubbish. So the next thing is that the police are on side trying to investigate mum. Mum's still under the influence of her sedative medications. Dad is desperately trying to keep the police away from mum for no other reason than he can see that his wife is on the cusp. She's got a mild mental health background, which is clearly coming to fruition. And there's a few conversations going on with the burn service who are saying those legs don't look great, probably need to get an escharotomy done. There then ensues 2 to 3 hours of trying to work out where the emergency department will do those escharotomies. That's basically what was required. You can see how those legs are ischemic, unhappy looking legs. And unfortunately what happened is the child didn't get transferred despite us saying, just put it in an ambulance and get it to us, for please, just if you're not going to do it, we need to do it. Fairness to the emergency department, they were making many phone calls trying to get this child in the right ambulance, but they were trying also to get their neighbouring hospital, which is the trauma service, to provide someone to do a paediatric escharotomy because nobody in the hospital was willing to do one. This is the escharotomy that we did when it arrived, with the foot already in extremis, and you can see the black toe, that's the tip of the big toe there, is starting to become necrotic. And this is what happened over the next 10 to 14 days, is the poor child ended up with non-viable feet because of the evolving compartment syndrome in the lower limbs and the inability to do a timely escharotomy. Salvaged, had some BTM, skin grafting, other bits and bobs, actually now doing very well. We'll need some future work on the feet, and everything else is settled. There was absolutely no safeguarding component with that child. I say some of the stuff that mum went through was very sad, shall we say. And what really tipped the boat on this one was we ended up having to do a divert en route to the burn service, to a different burn service, because the child was getting very sick. and ended up arriving with a lactate of 26. So the problem is that you can very easily get distracted by good resuscitation. Actually, the key thing was what it looked like with a shocked child on admission and a lactate of, what did I say, it was 8. Because actually that's a really sick burn presenting sick at the point of arrival, who recovers well with some good, excellent, in fact, resuscitation interventions by the emergency team that were there. And then everybody got distracted by the bullshit of administration, who does what to when and whom, and who, which boundary, which border, which whatever. And everybody lost, they dropped the ball because they failed to recognize how sick the kid was at the beginning, and the kid was only ever going to get sicker in transfer. So again, there were lots of learning points from this particular case. Thankfully, it's rare, but it doesn't mean it's not going to happen again. And just because I know I'm coming to the end of my time, I'm just going to say there are not many burns beds in NHS England for paediatric burns. We've got 10 centre level ICU beds and one sort of at unit level, with perhaps another 20 or so sort of high dependency capable beds. But they're sort of the ones that are shared within paediatric critical care units or high dependency units on wards, and can be occupied by any other surge, such as RSV or any other illnesses or surgery that's being done at any other time. So they're not necessarily burn specific beds. This was the Shoreham air show disaster. The reason I show this is just to paint a picture for consideration. For those that remember it, there was a Hawker Hunter plane. The pilot decided to do a loop-the-loop, but did it wrong. He was only about 3 degrees off at the top of his loop, but it meant that he came down too low and ended up careering down the A27 and straight past the whole lot of people that were picnicking at the side and watching the air show. 15 casualties taken to hospital, including the pilot, and 11 killed at the scene. Why is this pediatrically relevant? Because if you look at the inset picture and you see the little building in the corner, the notice above the veranda there says Lancing College. Lancing College is a school taking up to sixth form, and all of their playing fields are just the other side of the A27. So had he made a mistake of 5 or 6 degrees, rather than careering down the A27, he would have potentially careered into the playing fields of the school. Clearly, the mechanism of injury at that point would have been horrific, with a large number of paediatric trauma casualties, but a significant number of which potentially with burns. That would have overwhelmed the UK. Full stop, no further discussion. There would have not been enough paediatric burns beds to manage a disaster of that nature. Again, Grenfell, we know there were a large number of 72 people that died at the Grenfell disaster. But again, we would only need a few burns casualties, paediatric flavoured, to overwhelm the UK burns services. What does that mean? Unfortunately, you hold them for us until we can work out where to go. And that hold can be up to 96 hours. So where we struggle now for transfers within that sort of 12-hour range, 6 to 12-hour range, because you might need to do an escharotomy and we can't find there is no one who's willing to do it. You may be holding them for up to 96 hours in the event of a genuine burns disaster. And although children would be a priority for redistribution around the country, that's going to take time in the event of a mass casualty response. So we do need to think much more pragmatically about how emergency medicine can support the needs of the child in the event of something like a burns disaster. This was interesting, but I'm going to skip through it. We did a big simulation, basically, and the conclusion was we were lucky with the simulation we coped with, and we had outcomes that were not above. We dealt with it, basically. We dealt with the casualties, but it wouldn't take much beyond what we did on that day to have overwhelmed the UK. And the reason is that, for example, if the exercise had occurred during this lull phase that we see, there was a natural surge in summer burns that occurred. which if we'd had the disaster and already our beds had been filled by disaster patients, because that occurred during the lull phase, actually we would not be able to cope with the ongoing demand for burns that occurs within burns in the months that followed. So again, burns trauma patients often end up with a short hit. It's a couple of days, maybe a couple of weeks at the most, that they come in, they get their operation, they get something sorted, they get a fracture fixed, they get something else tweaked, they recover, they get discharged, they go home. The tail after the disaster is very short. Manchester bombing is a prime example. Actually, virtually all of it was back to normal working within 2 weeks. A burn disaster would last months. Most patients would be in for between 20 to 50 days in the critical care, intensive care environments, and their rehabilitation phase would be measured at months. So the tail of a burns disaster lasts for months, not days and weeks, and that's why our services would struggle following something along those lines. So look, skim through these. Cool. Look, 5 minutes past 11. Let's just say burns are complex. It's always going to be a challenge in a mass casualty scenario. Important, I think, not to get distracted by the burns. I think I'm going to leave it there. How's that?
Thanks, Mr. Martin, for this comprehensive overview of burns and the interesting case studies at the end. I guess if anyone has any questions, you can feel free to ask or put it in the chat.
If there's not many chat comments, that's not a problem. But if you do get anyone coming to you with questions later on throughout the day, or things turn up, then just ping them in an email and I'll give you some answers. Then you can sort of distribute it to your wider team.
No problem.